Hi, my name's Dr. Ross Hauser. Welcome to Caring Medical. I'm here with my associate, Danielle Matias, and we've both been doing prolotherapy for a lot of years. I took over the practice of Gustav Hemwall, who was the world expert in prolotherapy from the death of Dr. Hackett, who died in 1969. So Dr. Hemwall was the world expert from 1969 until his death in 1998. I joined him in 1993, so I've been doing prolotherapy since 1993. I received my first prolotherapy treatment on my neck in October of 1992 at a prolotherapy conference. In 2012, I had the most amazing physician assistant student, best I ever had, who was Danielle, and at the time I was trying to find a physician to join me, but Danielle was like 10 times better than any physician I had ever seen. The first time that I had Danielle in the office as a student injecting patients, it was like she was a savant. She was just unbelievable in her skill set. And over the last 10 years, it's been an honor to work with you. And even within a couple of years of us working together, I told patients that you're one of my teachers. So, and you know that's absolutely true. Like even the other day, right, when I had one of my patients and I asked you to come in, like I absolutely was learning from you. And I think that's partially what makes it fun for us, right? Because we're always learning.
Thank you for those kind words. But absolutely, we've been working together for almost 9 years. And so I would agree, it's not uncommon to pull each other into rooms to like help me with this, or hey, let me show you, this cool thing.
Yeah, and then, with ultrasound and the technology we have, we can absolutely, guide the injections. And I thought we would just start with kind of the main injection techniques that we do in the office here, and we have them listed here.
Sure. So patients, a common question we get is, what is prolotherapy, or how does it work? There's different types of prolotherapy. That is basically just an umbrella term, I would say, for several different types. One of which, as you can see behind us, is called cellular prolotherapy. So when people hear PRP, platelet-rich plasma stem cells, those are forms of cellular prolotherapy where we actually use cells from the patient themselves and inject it directly into injured areas. Mm-hmm. The more maybe severe the case, or if a tear is involved, that would be when we would often reach for that. The most common type of prolotherapy, I would say, when patients hear that word, is Hackett Hauser H3 Prolotherapy, where we actually use dextrose to attract cells to the area for healing. So we inject that into the injured area to get the body's immune system to mount a response to heal. And I would say that's probably still the most commonly used around the world.
Yeah, no, definitely, and it's growing, especially in countries where maybe they don't have as much technology as we do in the States here, because it's inexpensive. The solutions aren't expensive, and it's very, very safe. Dextrose, you can use it on every part of the body. So, like for instance, I had a patient today who we used 16 syringes of solution, so you can, basically do multiple body parts at one session, and it's very, very safe.
Yeah.
The interesting thing about Hemwall Hackett Hauser prolotherapy is many of the innovators in stem cell and other injection techniques started as prolotherapists, as traditional prolotherapists. As you know, I showed you that email from Dr. John Liftoff the other day. Dr. Liftoff, in my opinion, is one of the most brilliant physicians that was ever born. He, years ago, he took the book Prolo, Your Sports Injuries Away that I had written, and was doing traditional prolotherapy. And what he did was he did some experimenting of different concentrations of dextrose solution, and he found that just a 5% dextrose solution could stop the nerve impulses of peptidergic nerves, and also it can help their function. So then instead of being irritated, they would then fire only when they needed to fire. So it was very successful at eliminating any sort of neurogenic inflammation. So he used to call it neurofascial prolotherapy, and he changed the name to Liftoff Perineural Injection Therapy, which is basically an injection technique where there's very small nerves on the skin that are sensitized, which we call those peptidergic nerves. And when you inject 5% dextrose and other solutions in those nerves start functioning normally. They don't give pain. And because it happens immediately, like it immediately turns off those nerves, the person gets pain relief immediately.
I would say, maybe just to clarify too, like this is, you mentioned it like a 5% dextrose solution, which is important because it's non-inflammatory. It's different than what we would use for like traditional prolotherapy, which is a higher inflammatory concentration of dextrose.
Yeah, anywhere from like 10% to 25%.
Yeah.
And then nerve release injection therapy is an injection technique where it's usually ultrasound guided. So a good example would be carpal tunnel, where you're actually using ultrasound to see where the median nerve is entrapped, and you're guiding the injection, and then you're injecting solutions that actually free up the nerve. The scientific term for that is called hydrodissection.
Yep.
And you can hydrodissect pretty much almost any nerve in the body. Like the other day we were doing the pudendal nerve for perineal pain, but we've done intercostal nerves, the brachial plexus, what
ulnar
else?
nerve, like for cubital tunnel. Yeah, I would say carpal tunnel, very common. The perineal nerve at the knee.
Tarsal tunnel.
Tarsal tunnel, the tibial nerve. Yeah, absolutely.
And then I told you the patient that I had the other day where they had, it was very interesting. They had a specific pain that went like up here, just like that. So then we can even do plexuses. So we did this superficial plexus, cervical plexus up here. Then, had the needle in the fascial plane, because a lot of times the nerves are between the muscles. They're in this place called the fascial plane. And you can see that under ultrasound. So I had the needle in there, went like this, and immediately the person felt zzz. And then in other words, like the solution, the 5% dextrose solution got around the nerve, and then within 10 minutes or so, the pain was completely gone. So it does treatment, but also does diagnosis.
Absolutely. And it's quick, or can be quick.
Yeah, exactly. Dr. Hemwall he basically retired in 1996 then. Him and I shared this desk. It was a really cool desk. He had it all of his career, where he's on one side, I'm on the other, and then the drawer, there was just one drawer.
Oh, funny.
So, it'd go on both ends. No, it's just very, very cool. Yeah. And then he was cleaning out the drawer, and he gave me some of the old pictures and old things. So he actually gave me this picture. They're at an American Academy Physical Medicine and Rehabilitation meeting in the 60s.
Wow. And
then Dr. Hackett was there with his young protege, right? So you see the old timer, young timer. Then here we go, 30 years later, then you got the old timer with the young, he's probably 85 at the time and I'm like 30. One of the things I was proud of is it used to be called Hackett Prolotherapy, and then when I wrote Pull Your Pain Away, I dedicated the book to him because he was my teacher. And then at the book opening party, which was in 1997, Dr. Hemwall was there. So before he died in 1998 at the age of 90, he did get to see the release of Pull Your Pain Away. And then around the globe, like if you look in Korea, because in South Korea, they've just done a great job of prolotherapy studies, getting prolotherapy accepted. And now there's prolotherapy associations in Italy, Pakistan, Saudi Arabia, so we're grateful for the growth of prolotherapy around the globe. And there's certain principles that Dr. Hemwall taught me that are known in regard to prolotherapy. So why don't you go through those?
Yeah, so when people think of or hear H3 prolotherapy, the biggest thing is that it's comprehensive. It's not one injection into the entire joint. It's multiple injections inside the joint and around at all of the ligament and tendon attachments to work to rebuild the joint as a whole. Typically, 4 to 6 weeks between treatments, although that could be flexible based on the patient's case, of course. And we encourage patients to be active within reason, in between treatments. Like we do want them to use but not abuse their joints, which of course is tailored to every patient. Like you touched on this earlier, multiple body parts can be treated at the same visit. So because dextrose has a high safety profile, we are able to do that. like both knees or, things like that. And then again, dextrose is the main proliferant, although other additives, minerals, fatty acids, things like that can be added to change the solution as needed.
I often say that if you have a condition that has at its origin a ligament etiology, like in other words, you have a ligament disorder like Ehlers-Danlos syndrome, or you have joint instability and it's a ligament problem, you better go to a ligament specialist, because if you go to an orthopedic surgeon and you get surgery for a ligament problem, it's not going to be good. Arthroscopy, as we all know, during an arthroscopy, it actually swells the joint, so that's gonna just stretch out the ligaments. If you get steroid injected in there, or you take an anti-inflammatory or pain pill, it's not going to do anything to regenerate or tighten a ligament. And most people never even heard that they have a ligament problem. So why do you think that is?
Well, I think kind of like what you said, if people have joint problems, they might traditionally go to orthopedics, chiropractors, other medical professionals who do a great job, but ligament injuries often do go undiagnosed. They often do go unrecognized because traditional imaging like MRIs and things often don't pick up on those problems, especially in joint instability. You need to move the joint to actually understand whether or not it's unstable, either with or without imaging, such as ultrasound.
I have had patients say, well, why didn't the doctor do an ultrasound? Right. I can't say why they didn't, but a lot of pain practices, they don't have ultrasound. And with ultrasound, you can stress the joint, and then you see the two bones move too far apart, and then you know that you have a ligament injury. And if you actually study ligaments, ligaments basically are gram for gram stronger than steel.
It's incredible.
And then 90 to 95% of the ligament is made up of type 1 collagen, so it's a specific type of collagen. Cartilage is type 2 collagen, so that's why with cartilage issues we might use something beside dextrose. It's actually a different kind of collagen, so we might use PRP or stem cells for cartilage problems. When you have one ligament injury and it doesn't get resolved, the forces go to the other ligament. So then that's why we often say that ligament injury is a progressive disorder. So you have a ligament injury here on your medial collateral ligament. It may seem like a simple problem, but if you don't do something about it, your ACL, your lateral collateral ligament, is going to get injured. Then once this joint is loose, then it means that the next joint's going to get the force, and then the next joint's going to get loose. When I was researching one of the books, it was actually kind of surprising, because you learn that the cartilage doesn't have any nerve endings. Right. So if a person has knee pain, your knee pain, it's not coming from the cartilage, because the cartilage doesn't have any nerve endings. Most of the nerve fibers, the nerve sensors in the body, are from the ligaments.
Yeah, so when I explain this to patients, most people have sprained their ankle in their life, and I'll say, have you sprained your ankle? They'll say, yeah. Say it hurts. It is so painful when you sprain your ankle. Everybody knows this. And it can actually even be more painful than breaking your ankle, because there's so many nerve endings in those ligaments. So if you have a ligament injury in your knee, in your shoulder, it's nothing to joke about. They can be very painful just because of all those nerve endings.
Yeah, exactly.
Yeah.
And then the ligaments in a large measure control muscle tone, meaning when you have a stable joint, then when you want to move the muscle, it's under your voluntary control. When you have a ligament injury, there's a thing called the ligament muscular reflex. So just taking the knee, for example, when you stretch out your anterior cruciate ligament, then it means that when you're walking, the tibia bone is going too far forward on the femur bone. So then there's a reflex arc between the anterior cruciate ligament and the hamstrings. So then the hamstring contracts because the anterior cruciate ligament is stretched out, and that will cause your tibia to go back. So in other words, if your ligaments can't handle the extra motion of the bones, they'll recruit their buddies, the muscles. So that's the reason why people have chronically tight things. Like we all know the iliotibial band, when you have tightness in the iliotibial band and you stretch it and you go to the physical therapist and you do a bunch of stuff, but it never goes away. It's because you have lateral knee instability, and the ligaments there are through the ligament muscular reflex are recruiting the iliotibial band. And I think that's really important, especially for athletes to understand, like, you know,
Yeah.
because if it's just a tight muscle or a tight tendon, you could just go to a masseuse for an hour,
Yeah, and that'll be fine.
But we know that it comes back. Why does it come back? Because it's there to stabilize the joint. This is actually Dr. Hackett's original figure. I mean, we
cool.
obviously made it color, but in the book that Dr. Hackett wrote in the 1950s, which I'd encourage anybody who really wants to study prolotherapy, get a copy of Ligament and Tendon Relaxation Treatment by Prolotherapy. That's Dr. Hackett's original book. It's in its 5th edition. And no, I mean, it was very innovative in the 1950s to come up with this. So why don't you go through the degenerative cascade and
Sure. If someone gets an injury, like they sprain their MCL, more structures will get too much force, they'll get injured. You'll start to wear down cartilage, you'll start to wear down meniscus, you might grow bone spurs. Obviously, you don't want to go down that way. We can actually treat those tissues, strengthen those ligaments, and regain stability. Obviously, it's easier to do that sooner rather than later. You know, the longer something has gone on, the more chronic, the more degenerated it is, it's much harder to work with that. But especially when you catch things on the sooner side, it's easy to restore that stability so patients can continue to be active and live in a high-functioning life.
Yeah, I think this kind of summarizes the body's way that the body stabilizes a joint, because the body will find a way to stabilize a joint.
Absolutely.
And sometimes the body will give you so much pain that it'll say, no, you gotta just not move it. And just not moving it is going to stabilize it because everything's going to tighten up.
Sure.
But that's not ideal. So initially when you get an injury, we talked about that you get a ligament muscular reflex, you get muscle spasms. So if somebody has chronic tension in their neck and they get a massage or they get lidocaine injections or trigger point injections and nothing gets rid of it, it's got to be that the muscles are contracting to try to stabilize your neck. So you really should get an evaluation for neck instability. And then most people don't realize it's the cells that line the joint, the synovial cells, that produce the joint fluid. So the normal joints of the body, they're only supposed to have 1 or 2 cc's of joint fluid in them. When you get joint instability and all of a sudden there's extra motion in the joint, the synovial cells move more, and it's the movement of those cells that actually cause the joint fluid to be made. So when there's extra movement, the synovial cells make extra fluid. So joint swelling is basically diagnostic, if you will, of joint instability. I mean, that's the reason why you have joint swelling. So the treatment shouldn't be take an anti-inflammatory or a steroid shot, because then you've stopped the body's protective mechanism. And one of the reasons that the joint's swollen is to protect the cartilage, protect the other ligaments, because the person's still going to walk around, say if they got swelling in their knee, and you know you have swelling in your knee because if you touch the swollen knee versus the non-swollen knee, the swollen knee is a little bit warmer. So just that's a way that you know that you have a little bit of synovitis or swelling of the knee. And long term, if you have instability on the medial side of your knee, you're going to eventually develop a bone spur there, because the body will calcify that ligament. It'll eventually cause a bone spur to grow along the line of that ligament. So bone spurs, when I was starting out in the practice, they would do these clean out arthroscopies, but they found out that when they cleaned out all the bone spurs, the joints got unstable, so the results weren't good. So that's one of the reasons why they don't clean out bone spurs anymore. So you don't get rid of most bone spurs because they actually do have a good effect. And then obviously prolotherapy, we want to stop the arthritic process, stop bone spurs from forming. So then we get the joint stable, and then the swelling stops, the muscle spasms stop, the pain stops, and people get back to their activities. If one looks at the biology of prolotherapy stimulates inflammation. And let's be honest, I mean, most of us work out a little bit. That muscle stiffness that you get with a workout, you actually inflame the muscles, you broke down the muscles, then you get stronger muscles, more efficient muscles. Well, the process of all that it goes through this. Like I've done 5 Ironmans. So in other words, compared to somebody who doesn't work out, if you took a biopsy of the muscles of somebody who works out a lot or has done a bunch of Ironmans, you'd see that that person who works out a lot would, in the muscle tissue itself, would have more mitochondria, more blood vessels, all these different things. Well, prolotherapy does that same thing for non-muscular tissue. Muscles have a really good blood supply. Prolotherapy is used in the structures in and around the joint. Everything in and around the joint is white. The cartilage is white, the ligaments are white, the tendons are white, meniscus is white, labrum's white, disc is white. So white tissues have a limited repair capacity because they don't have a good blood supply. So you could exercise and it's not going to cause a stretched out ligament to tighten. So when we do prolotherapy, even with dextrose, it's a type of stem cell therapy. In other words, when you have a ligament injury, and there's been scientific studies when you have a ligament injury and you look at the joint fluid after ligament injury, you can get up to 1,000 times more stem cells in that joint just from that one injury. So when we do prolotherapy with whatever solution we use, you're going to get cell proliferation. So the treatment prolotherapy stands for proliferative therapy. The first edition of Dr. Hackett's book was called fibroosseous proliferation. It wasn't until the later editions that he actually coined the term prolotherapy, but it was called fibroosseous proliferation. And why do we say fibroosseous?
Because our main target of prolotherapy is actually at the junction where the tissue attaches to the bone. So fibro meaning, the ligament or the tendon, osseous meaning bone, that's actually where we want to make sure that we do injections for optimal healing.
Yeah, the place where the ligament actually grows is called the entheses, where the ligament attached to the bone. So after prolotherapy, you get cell proliferation, you get cell migration. Like when there's an injury, there's all kinds of cells, and most of the stem cells actually come from the bone marrow that's right around the joint, but it also can come from the synovium. You can get stem cells from the synovium. So in other words, you injure a ligament here, or you do prolotherapy here, there's going to be stem cell migration, growth factor migration from the bone marrow stem cells as well as the stem cells in the synovium. And ultimately what you're trying to do is just make new extracellular matrix. Like you're trying to get the ligament tissue, the cell matrix, the ligament tissue itself stronger, thicker, able to withstand more forces. And that's why prolotherapy often has a very long-lasting effect. Not that every patient gets cured or stays cured, but I think I told you this story. This was just the other day. I was walking between the 2 buildings and I saw somebody, and then the person said, "Dr. Hauser." I go, "I know you don't." And he said, "Yeah, hey, I got to tell you a story." So person's a gym teacher, and we did make a video with him. He's a gym teacher. Was a wrestling coach for like 34 years. Well, basically in 1996, he had a meniscectomy. They took out his meniscus. Then I saw him in 2001, 5 treatments on his knee. Then he told me that there was many years later, like 15 years later. So let's just say if somebody had a meniscectomy, what do you think their knee would look like 15 years later?
Oh, not good. The arthritic, not good,
So literally, he went to the orthopedic for a hip problem. Then he told the orthopedist, same side, he said, "Hey, could you x-ray my knee?" Then he came back and he's looking at it and he's like, "What's wrong with your knee? Like, I don't see anything wrong here." And he goes, "What do you mean?" He said, "No, it's like, it looks like a perfectly normal knee." So then he told them, in 15 years before I had gotten prolotherapy, and I don't know if I did PRP or did it.
Sure.
But, and then even the orthopedist said it has to be the prolotherapy, because it isn't just he was doing nothing. He was a wrestling coach.
Yeah.
Do you know how much strain he would have had on his knee? And
Wow.
So there are times that prolotherapy does, in essence, cure the problem. But of course, there are times where that's not the case. So what would you say if somebody asked you, like, is prolotherapy permanent? Is it not permanent? Like,
I get that question every day. And so here's what I say is, we work on healing soft tissue injuries. Nothing we do is going to make this joint bionic. God forbid you have a nasty fall or something, of course you could re-injure structures. But currently, you have an injury, you're in our office, your joint, that tissue is degenerating very quickly, because it's injured. We want to heal it, and then, it will start to degenerate at the rate of the rest of your body. It's just you'll start to age it. Depending on your activity level, depending on your health, depending on, lots of other factors, will help determine if it's a pain-free joint the rest of your life, or if you are somebody that may need tune-ups. We have some patients that are even like Ironman athletes that, maybe had a knee surgery years ago, and we see them for tune-ups just to kind of keep them going and keep them training every couple years. Some people I'm seeing a lot of patients that were your patients, maybe 10 years ago, who are like, hey, it's starting to, my knee was great for 9 years, and the last year, it's maybe starting to hurt a little. We do a couple treatments and keep them going. So I would say there's kind of a spectrum there, depending on the patient case.
Yeah, and maybe I'll just use me as an example, because I had prolotherapy 30 years ago. So my ankles, I always would sprain my ankles, and then for my both ankles, I only needed 3 visits. And then, so in other words, like 28 years ago, I had 3 visits on my ankles, and I have never had my ankles treated again. And I did probably 100 marathons, I did 5 Ironmans, so that it was very successful. In 2008, I was the first stem cell patient at Caring Medical, so I try to make sure that the treatments are safe and so I do them on myself, or I have my staff do them on me. So I had 3 stem cell procedures with bone marrow, 3 or 4 on my knee. Then I was training Ironman and doing all kinds of running after that, and I was good till 2018. I think, I started having you and my staff treat me. Then I got 3 PRP treatments in 2018, 2019, and then I'm back to running. Then as you guys know, I'm very emotional, so I tend to have bruxism. So every once in a while I need like my TMJ, which you've been great at that. And then my albatross, of course, is my neck. That's why I kind of know so much stuff about my neck. I've had drop attack, I've had nausea, I've had dizziness, tinnitus. Way back when, I had a bunch of treatments on my neck, and then really I didn't have treatment, say, on my neck for 12 years or something. Probably in the last year, maybe I had 1 or 2 treatments on my neck. So anybody who knows me, I research a lot, so I'm always hunched over. My work as a prolotherapist, we're hunched over. I swim, so I'm very hard on my neck. So for that reason, I'm in that category of 5 to 10% of our patients. It's not that much for a chronic pain practice. Like, we only have 5 to 10% of our patients are what I would say chronic tune-up patients, where like my neck, I get it treated, once a year or whatever.
Years and years ago, when we were both working in Illinois, I sprained my elbow playing beach volleyball, and I was within a week. Like, I saw you treated it. It was like 2 treatments. It's been awesome ever since. We caught it, it was like super early, but I also almost nearly completely ruptured the ATFL in my ankle. And so that one has been like a more maybe chronic thing. Like, it was a nasty injury to start with. And so when I was running half marathons and things like that, like, I did need more kind of tune-up treatments for that. So it does depend.
That's a good point. I should state, my dad and I were in a horrific car accident when he was driving me off at the golf course in Waukegan, and we got hit going 40 miles an hour behind us, and we didn't have seat belts on because you didn't do that in the 1970s. So already by the time I got my first prolotherapy, which was 17 years later, I probably had like unbelievable amounts of arthritis. So just know my neck injury, it wasn't just me studying and research things. I had a really, really bad car accident. And then my dad and I both ended up with a lot of arthritis. And then he hasn't had to go to any other place, just prolotherapy, and I haven't had to go to any other place, never had surgery or.
That's good. We get a lot of questions from new patients and even follow-up patients, and these are kind of, I would say, kind of most common questions that we get. Why would you not always use stem cells or PRP now that that technology is available? You know, I would say I get that question every day.
Yep.
And it all matters on the extent of joint damage, you know, quite frankly. To use the analogy I had earlier, when I sprained my elbow, that was like a week or maybe 2 week old injury. There's no reason to use stem cells when it's that acute typically. Usually dextrose prolotherapy comprehensively is all that's needed to get that healed. But if somebody's had pain for 10 years and they've got more advanced arthritis, or even in cases of tears like meniscal tears, labral tears, those might be cases better suited for PRP or stem cell. You don't always have to do the most invasive, expensive procedure to get the same results.
Technically, even if you go back to the Hippocratic Oath, the sentiment of it is a physician or a healer is supposed to do the least invasive, least traumatic. You know, once you start using PRP or Lipoaspirate or bone marrow, I mean, it is way more inflammatory. It's not even in the same ballpark as like regular dextrose prolotherapy. Also, lipoaspirate and bone marrow, I mean, it's invasive into the body. You're sticking a probe into the fat, or else like you're drilling into the bone marrow.
Right.
I might just comment on when I might use bone marrow, because I do have some patients who it really was the bone marrow. As you know, in the office, we do see a lot of Ehlers-Danlos, and we see really cases where there's just a lot of joint instability all over. And I tell the client, if they had an identical twin, so we're going to treat the one twin's knee, that's all the twin has is the knee, that's it. And the other twin has like 12 body parts that we're going to do each time. Well, obviously this knee is going to be 3 or 4 visits probably, the twin that it's just the knee. But when you have to, when your body has to heal 12 body parts, it's not so easy for the body.
Sure.
So that one knee may be 6 visits. Because you're not really, all the resources of the body aren't going to heal that one knee. So in that sense, how can we get the body maybe to heal 12 body parts kind of equally to that? It would be that, well, we're going to take out bone marrow, or we're going to take out fat. And the reason why we might use bone marrow versus fat is to inject the fat, you have to use a much bigger needle.
True.
So if you need, you know, like 12 body parts, you're going to choose bone marrow over lipoaspirate, because you can't take a really thick needle and be sticking it all over the body. But if you just had a hip joint or a knee joint and you wanted to use stem cells because the joint was just really had a lot of advanced degeneration, then you could use lipoaspirate.
Well, and patients also will say, well, what's better? Like, I want what's best. What's better? Is it bone marrow or is it fat? And what I say is they both work really well. But if somebody comes in and they're a highly competitive athlete with 2% body fat, we may not get a good fat sample, you know, so bone marrow would be the best for them. But maybe someone that's older with, you know, osteoporosis or something comes in, maybe we don't, you know, want to drill into their hip bone, but they have a lot of fat, you know, we may want to use that because that's going to be the best sample for that patient. You know, there's not like a one answer fits all.
Yeah, I'm just kind of smiling because, you know, again, because, you know, you go on the internet and there's exosomes and there's placenta and there's, you know, there's a million different solutions. And I'll just say to the person, what do you think in regard to prolotherapy, what's the most important piece of the puzzle to get better? You know, it's a very interesting question. Yeah. And the answer, we all know the answer once I say it, it's who's your prolotherapist? You know what I mean? Like, you know, like you could say, like, it'd be like surgical techniques. Like, I got to get the best surgical techniques. Much more important than what surgery you're going to get is the surgeon. Like that, you know what I mean? It's the surgeon, because when the surgeon gets in there, there may be something unusual or da-da-da or da-da-da. And then and it has to be a surgeon who like really cares about you as a person. Yeah. You know, versus like, oh, there's some great technique or this or that. It's like, oh my gosh, much more important. And I said that you have this joint problem, right? The major problem is the ligaments, which are around the joint. It's not the joint. You don't need some fancy schmancy thing that costs $2,000 for the solution to put it in there, because it's not a joint problem. It's a ligament problem causing the joint problem. So So it's actually where the needle tip is.
Yeah.
And who decides where the scalpel is or where the clamp is?
That's a good
or
analogy.
it's the prolotherapist. So to me, that's the most important thing is choosing the right prolotherapist. Now, well, obviously we got to talk about risk.
Yep.
So anytime you pierce the skin, there's a chance of infection. Yep. So the most serious infection, of course, are joint infections. So I've been doing this for 30 years. So about once out of every 10 years or 8 years, a busy prolotherapy practice is going to get an infection.
Yeah.
So you got to recognize it early. But it's very, very rare.
Yeah.
And then I often tell people, you always got to remember, if you have a chronic pain problem, especially if it involves your neck and it's screwing up your neurology, your whole body, the most dangerous thing is not to get that resolved.
Yeah.
Because joint instability is a progressive disorder. And then if you're older, once you lose the ability to walk, your mortality goes way up. It's very important that we got to stay active. So the major risk with prolotherapy, what does occur with most patients is you do get a little bit of bruising. So technically you could say that's a side effect. You are going to get pain for 2, 3, 4 days.
Swelling, stiffness, that's all considered normal, really.
Yeah.
Yeah.
The most serious risks, and again, this goes back to choosing your prolotherapist. The most serious risk with prolotherapy is where the needle tip is.
Yeah.
That needle tip can go into a nerve.
Yep.
That needle tip can go into a lung. So again, it's your prolotherapist. It's choosing the right prolotherapist. So,
what would be some reasons that people would quote unquote fail prolotherapy? And patients ask that, and we would be lying if we said we cured or helped every single patient that we saw. We obviously do a good job of finding and treating like really good candidates and so forth. But I would say, in my experience, the most common reasons that people fail prolotherapy is, well, I would say 2 reasons. One is they are doing too much, like in between treatments.
that was what I was going to say.
Yeah, and I actually had this recently happen, and this woman, she was so sweet, and she said, like, you need to tell me exactly what to do, like, I will overdo it. Like, she told me that on day 1. So I said, okay. So on her paperwork, at the biggest, boldest, like, capital letters, I was like, I literally said, no running, no mountain biking, whatever. So she comes in for a second appointment, and she's like, I was doing so well, and then I went mountain biking. And I was like, what? And I like pulled up her paperwork, and I was like, did you see the big bold letters? And she's like, yeah. And then she hurt herself is what happened. And so I said, okay, from now on, you're taping it to your fridge. There's no question. But I would say that's case in point why. We want you to use it, but you can't put too much force on it in between treatments as it's healing. So I would say that, and patients that maybe stop too early. If we say, hey, on your initial eval, this looks like something that's going to need 4 to 6 treatments for it to completely heal, but they only do 2, they may say like, oh, I failed prolotherapy, when really, they probably didn't give it the best shot that they had at healing.
Yeah, what I'd like to do is just make a distinction between people who've gotten prolotherapy by another clinic and then prolotherapy by our clinic. Because, it's common, we get emails from all over, prolotherapy didn't work for me. And when they've had prolotherapy by another practitioner that's not in our practice, I ask them, or our staff asks them, how many injections have you gotten? Because in regard to the joint, like if we just take the shoulder joint, it's actually a ligament mesh.
Yeah.
Like on Google or in a book, it'll say, oh, there's a glenohumeral ligament, and there's 3 different parts to it, and da-da-da. But actually, in an actual human being, it looks like a mesh. So we treat the whole mesh. Shot here, shot there, shot there, shot there. It's like spot welding.
Yeah.
It's more like spot welding than like one shot into the joint. So often the people will say, well, I only got 1 or 2 injections. And so when you get only 1 or 2 injections, it means that the person's putting them primarily in the joint. And when you use really strong proliferants inside the joint actually swells a lot.
Yeah.
And there's people that put in 10 cc's into a joint when the normal shoulder joint or knee joint normally only has 1 or 2 cc's of joint fluid in it. So now all of a sudden you've expanded the joint, and then that stretches out all the ligaments. So it's no wonder that the person didn't get help by the prolotherapy. So comprehensive prolotherapy, or Hackett, Hauser prolotherapy, is where you're treating the whole mesh, and most of the injections are periarticular or around the joint versus in the joint. So I think that's a really big distinction. The other thing too is often when we asked the patient, did the prolotherapist, the other prolotherapist, give you any guidelines as far as you should brace, not brace, you should run, you should not run? And they say no. So of course, they get prolotherapy, they feel relatively well after it because, you know, the joint's swollen, so they're stable, right? Because, you know, especially if they swelled it a lot, so it might be stable 2 weeks later because artificially, then they do a bunch of stuff, then of course they feel worse than ever. So those are the kind of the common reasons that people fail from other prolotherapists.
There was a study years ago, and it was on PRP for ACL tears. And they did PRP injections on athletes that had ACL tears and then let them go run. And they were like, oh, it doesn't work. Like,
wow, that's terrible.
Of course it doesn't work because you did, like, on ACL tears, you did one shot of PRP and let them go run. Like, it's, so.
We haven't talked much about the proliferative cascade. Really, to get all the strength back, I mean, it takes months.
Yeah.
I often say that ligaments are the turtles of the body.
I've heard you say that,
we live in Southwest Florida, so a turtle could stop traffic.
I've seen that now.
You know, yeah.
Not in Chicago. But yeah.
Meaning that we cause ligaments to grow slowly. Like prolotherapy starts the healing cascade in ligaments, but ligaments are still turtles. And so throughout the process, throughout the 3, 4, 5, 6, 7 sessions of prolotherapy, then the ligament's getting stronger, so you can put a little bit more force on it. And people always have to remember too, you have to build endurance before speed. Meaning that when I did my Ironmans, imagine like you finish an Ironman, you take 1 or 2 months off to rest, then you're gonna start training again. The coach would always say, you have to build endurance, because when you build endurance, then the tissue can handle the force of speed. So meaning that if you've been injured as an athlete or a regular person who likes to exercise, the first thing you have to do is like walk, and then you build up how much you walk, and then when you start jogging, you just jog really slow, 2 minutes, 3 minutes, then walk 2 or 3 minutes, jog 2 or 3 minutes. And you very carefully then, with the help of the prolotherapist, figure out, you know, when you can actually start sprinting. So it isn't like you feel good, then you go sprinting. You have to.
Well, and with that, what I tell patients is you will actually feel better before that tissue is as strong as you think it is. So it doesn't mean, okay, maybe it's going to take 9 months for it to be completely stable. It doesn't mean 9 months to feel better. You'll feel better along the way. But, like, let's say after one treatment, you might have a day where you feel really good. Don't push it. You're feeling good because things are healing, we're moving in the right direction. It's not healed after 2 weeks. So there absolutely is a progression of exercise in between each treatment. It's like how much more stability you've gained that we can feel, that we can see on ultrasound. Then that's how we will coach them on how they can progress with their exercise. I think what's important too for patients to understand is healing is not linear. You don't wake up every day better than the day before. It's up and down. Like, you've got good days and bad days, and things ebb and flow. But as long as we are ebbing and flowing, like in this upward trajectory, that's what we want to see, you know. And pain is kind of fickle. You know, you might have a bad night's sleep and a stressful day and your shoulder hurts. Doesn't mean you got a new rotator cuff tear from like stress. It just means like, yeah, you need some rest, and you know, maybe your pain is better the next day. Or I use this analogy, like Publishers Clearinghouse, I don't know if they still do that, knocks on your door and gives you a big check, you might jump up and down, like, what meniscal tear? Like, I don't feel anything, like, I feel amazing. Like, did that, like, $1 million, like, heal your injury? No, but you just, like, feel good, like, emotionally. So there's a lot of outside factors that kind of dictate, like, how patients feel, like, with their injuries day to day.
Yeah,
so just things that are important, I think, for all of us to remember.
Yeah, you know, and this is just subjectively, but years ago I actually realized in general 2 out of 3 people when they come for their second visit feel some improvement. So it does mean 1 out of 3 on their second visit just say, I can't say that I feel any better. Then on the 3rd visit, so in other words they've had 2 prolotherapies, it's 3 out of 4, meaning 1 out of 4 still don't feel any improvement. So Well, let me ask you this question because it's kind of a good question. When would you say to a patient, nah, I just don't think we should continue with prolotherapy?
Yeah, it's a good question. I would say,
like they've done what you said to do. They're
yeah,
very good clients.
like they're compliant. Like
Yeah,
we've
yeah.
tried, we've maybe changed solutions, changed
Yeah.
bracing, changed things. I would say typically, like if we get to like, I'm concerned by treatment 4, maybe by like treatment 5,
Yeah.
like I would consider calling it, so to speak.
Yeah, I think if somebody has an added improvement and they're on visit 4, I always say we got to go back to like as if this is your first visit. Like,
Yeah.
let's look at the MRIs again. Let's do this, that, and of course you have to go through exactly what they're doing.
Right.
And we over the years I've had a lot of crazy things. I had this just to tell you one story. I had a fireman from Wisconsin. He was on their 4th or 5th visit, and he was doing everything I said. Then I said, my knee, it's interesting with my knee because, I married a gourmet chef who loves cheese.
Okay.
And I have a dairy allergy.
Okay, yeah.
And it's like, there's cheese, oh, I want to eat cheese. No, so it's interesting because I won't have any knee pain, but if I eat too much cheese, just that a little bit of inflammation
Okay.
from the cheese. So long story short, so I asked this guy, I said, just by chance, do you drink milk? He's from Wisconsin. He said, no, but I'm just saying though, he said, he tells me I drink 1 gallon of milk a day. Like, no, that's
Oh
a
my
true
gosh.
story, 1 gallon of milk a day. I mean, he was a big guy. So guess what happened once I got him off of the...
No way. Wow.
His back pain was completely cured. So no, the point is there's other things that sometimes you just got to regroup and just make sure that, you're talking about these kind of things. Like what are some other factors that could be involved? And then I've had other patients like, Joanne, anything stressful going on in your life? They're like, oh my gosh, doc. I'm like, what? Well, my daughter who was on drugs, she's back in the house and it ain't going good. No, but because like, that's gonna be, it's hard on the body, and it may be a factor that we have to talk about whether or not that's contributing to the pain or not.
I had a patient once who I was seeing for low back and kind of, not a gallon of milk, but it was like treatment 4, like not better. I'm like, all right, like let's regroup. Like, what are you doing? And his dad was with him at that appointment. He's like, well, tell her what you do in the garage. I'm like, all right, what do you do in the garage? And he's like, I got a gym out there. And he's like, I tie this like ridiculous heavy belt to my waist and back, and then I do pull-ups. And I was like, that sounds interesting. And he's like, no, but that's an arm exercise. It doesn't like relate to the back. I'm like, okay, let's regroup. Like, tell me everything that you're doing. What does success mean with prolotherapy? That actually is very different based on each patient in general. Somebody might say, hey, I just want to walk around my house without pain, and that would be successful for them. And then some people, of course, want to do very high intense athletics, that they would never be happy just only being able to walk around their house. So success really is, did we help them meet their goals? Like avoid surgery, get back into the activities that they want, sleep without pain. These are just, some examples of how we might determine success based on the patient.
No, I think that's a good point because, and you've had this before where we might be able to relieve the person's pain somewhat, but because, like for instance, of the architecture of their ball part of their hip joint, in other words, the instability has caused damage to the ball part, so it's not a ball anymore.
Yeah.
So even
more
if
like oval.
Yeah, so even if we could get rid of some of their pain, but they're still waddling and they're always going to waddle because they have limited motion, we have to tell them, no, it isn't just about pain relief. You got to be able to walk 2 miles.
Right.
So we can't get you to walk without a waddle for 2 miles, so you actually have to get surgery. So there definitely are times where we recommend surgery. People should know over the years, because it's been 30 years that the clinic's been doing prolotherapy, so we definitely have scientific studies that we've done, and these aren't double-blinded.
Right.
I mean, it's basically, in a lot of ways, it gives a lot of valuable information in that in private practice, in a person's private practice, and you could see these are realistic results. It's not like chondromalacia. It wasn't like everybody got cured, in 15 months, in 69 patients. For a single practice, 69 patients, that's a lot of patients.
Yeah.
And then most of these studies, the average person got 4 visits. So the pain level went from 6.8 to 1.4. Glenoid labrum tears, the cure rate was very, very high. And then when we did our Thebes study, which involved over 700 patients, so there's not a lot of clinics that can say they had 700 patients, and each of those patients had 4 visits on average. So it's close to 3,000 sessions of prolotherapy. Wow. The cure rate, and now the cure rate, by cure we meant that 90%, not 100%, but 90% or greater of your symptoms were relieved. The cure rate in that study over all the body was 72%. So now granted, we're only following them for 1 year to 1.5 years. So it means that at 1 year or 1.5 years, it doesn't mean at 20 years or 15 years.
Well, and also too, 4 visits is, it's a solid number, but it's not uncommon for people to need 6 or so, where they really,
so if they
met all
just
their
had
goals.
4, they might be 60%
Sure,
better,
yeah.
70% better.
That's reasonable.
And for some people, that's enough for them to like function good, and I feel good enough, and I need to take a break.
Yeah.
I think one of the things we haven't talked about is when prolotherapy can prevent somebody from getting a surgery. Because we get asked that question, do I need a joint replacement? Should I come to you guys? So years ago, and all these things were over 10 years ago. So one time we looked at our charts of 28 meniscal tears, and when it was all said and done, 27 of the 28 did well with PRP, prolotherapy, and they didn't need surgery. Only 1 needed a surgery. Then in 2007, I thought it would be fun to look at our patients who came already having been told by the orthopedic surgeon that they needed surgery. So we followed 34 new patients. Okay. And then I pre-selected them in the sense that these were patients that I used our criterion of that they were a good prolotherapy candidate. Because there are going to be people that right away we say, nope, the orthopedic surgeon's correct. Yep. You have to get back surgery, you have to get neck surgery. So 34 patients have been told they needed surgery, but I, through our criterion, and we'll talk about that they were good prolotherapy candidates. When it was all said and done, 31 out of the 34 didn't need surgery. And the most common surgery that we prevent people from getting because we qualify them as joint replacement. So what's the normal criterion that you would use to see if somebody's a good prolotherapy candidate versus a total joint replacement candidate?
If patients have poor range of motion, especially with the hip, if they can't move their hip very well, they can't external or internally rotate it very well. Yeah. A lot of times with that, it's because that ball, instead of being a ball, is more like oval, or there's a lot of bone spurs that are like roadblocks limiting motion. Yeah. That would be a case where they should consult with ortho. Patients that have full range of motion, those are more likely going to be cases where we can prevent the joint replacement.
Yeah, that's good.
Yeah.
Question. No, because I even teach people, like say it was a shoulder. So in other words, you look at the good shoulder. Yeah. How close is the bad shoulder to the good shoulder? The closer it is, the more likely prolotherapy can resolve it. And then the spine, so in regard to whether or not we can help somebody with the spine, if somebody has myelomalacia, so they had an MRI, they have an MRI, and there's already showing damage to the spinal cord.
Yeah, they gotta go.
That's probably going to be somebody who needs a decompressive surgery and a fusion. If somebody has non-positional radiculopathy, so what that means is that most people will say, I have sciatica, like when I walk I get leg pain, but if I sit I don't have leg pain. So we would say that's positional. So when you have positional symptoms, so you walk, when you're walking, all of a sudden the space for the nerve is going down. Then when you sit down, it goes back like this. That means it's a ligamentous problem. When you have a bone problem, you have congenital narrowing of your spinal cord, or you have such horrible bone spurs where the nerve is getting strangulated or the spinal cord is getting strangulated. It's not positional because it's not positional. So when it's not positional, it means it's there 24/7, nothing helps, I lay down, I walk around, it's there all the time. That would be where it's not a ligamentous thing, it's a bony problem, and you need to get a surgeon to decompress that.
Yeah.